Well, welcome everyone to our palliative care supergroup quarterly support hour. And today we have the good fortune of having some friends of ours from North Mississippi Medical Center up in Tupelo, Mississippi, who have put together a presentation around respecting care, especially when we're dealing with culture and spirituality. So we're very appreciative for your presence today. We have Dr. Jamilah,
Jamilah.
Jamil Perkins from both of our presenters are from Mississippi as well. That's a big thing. But Dr. Perkins went to Meharry Medical School in Nashville, and he did some research time at Johns Hopkins, and she's become an expert with regards to looking at how health is impacted by the cultural and spiritual issues that we face every day. And joining her is Kalisa Mickell from Tupelo as well, and she's a nurse practitioner up at North Mississippi Medical Center, and they bring a wealth of experience. Kalisa has just been named to the board of directors for UAB Southeast Institute of Innovation in Palliative and Supportive Care Committee, and they're planning big things for this part of the country as well. And so, Dr. Perkins and Miss Mickell, I'm going to turn this over to you and um, to take over from here. Thank you.
All right, thank you so much. Good afternoon, everyone. First, we do want to thank Mr. Jamie for that warm introduction, and we would like to also express our gratitude for the opportunity to speak with you all today. Thank you to the president, Mr. Jamie and his team, for allowing us this opportunity. We've spent several months preparing, trying to develop in efforts to align our schedules to be able to discuss with you all today. And to be honest, I can't think of a more better time for us to be able to finally present to you all. And so at this time, we wholeheartedly thank everyone for their participation, to being involved in this very meaningful discussion. And so the premise of our discussion today, as well as it stems from a research article that I had the opportunity to present during my geriatric or palliative care rotation. And I was able to present this research article alongside Kalisa to my colleagues in internal medicine. And this was under the leadership of Dr. McElwain, who you all may know as your past president of your organization. And under his leadership, we were able to have some very meaningful and thoughtful conversations around this discussion. And so today we would like to speak on the article, Respecting Faith, Hope, and Miracles in African American Christian Patients at End of Life, and moving from labeling goals of care as aggressive to providing equitable goal-concordant care. All right. And so the goals for this discussion, as well as the goals for the author writing this research, is they wanted to be able to demonstrate how the term aggressive care is more often used to inappropriately label the preferences of African American patients than other groups, and also how this can sometimes demise or discount or even be very dismissive to the shared beliefs of African American community, Christians. And also, they wanted to be able to provide some insight to clinicians who care for seriously ill African American Christian patients by sharing their beliefs, origins, and the importance of scripture and biblical teachings to the African American Christian communities. And lastly, they wanted to be able to provide some kind of recommendations to help encourage open and respectful communication between African American patients and clinicians that has the potential to result in African Americans, regardless of their religious affiliation, being provided with equitable goal-concordant care. So, The first thing we like to do is lay out the foundation of what the end of life model looks like. Now, the end of life model that is most prevalent right now in the US, it is based on the cultural and religious beliefs of the values of the white middle class at this time. And the premise for this origin actually originates from a UK origin of the C. Saunders origin of end of life model. Now, the premise of this model is that it emphasizes the autonomous decision making and receiving supportive care that culminates with the patient transitioning at home and having key family members providing their care. Now, what is most concerning about this end of life model is that it kind of lacks the insight and key values that are important to other racial and ethnic groups, particularly for those who may not have key family members to provide that end of life care, or it may not account for the shared decision making model that is the hallmark decision method for many racial and ethnic minorities. So now, let's first talk about or discuss how the term aggressive care is inappropriately used in the medical setting. Now, this term was originally used in the pediatric population to denote concerted efforts to help identify those pediatric patients who were deemed as having increased high risk for morbidity or mortality. However, as the medical literature started to change and we started to see this term more, it started to take on a different definition, and the medical literature often referred to it as the opposite of palliative care in the last weeks or months of life. So some of the criteria that you can see in the medical literature, they would kind of denote aggressive care as describing an individual who may have had frequent emergency visits, ICU stays, or even hospital stays during the last 30 days of their life. They would also sometimes denote the use of chemotherapy within the last 14 days of life. And so, as clinicians or healthcare providers who are treating patients with either advanced cancer, those with dementia, or even those with terminal illness, the term aggressive care has also been described as, and I quote, the result of multiple adverse consequences that can decrease the quality of life and reduce the likelihood of what is considered a good death. Now, the term aggressive care is not publicly used. You don't find many people in the community using this terminology. And this perception of good death is actually based on the clinicians' ideologies of their lived experiences of what they may consider a good death to be. However, this can vary from individual and it's not in opposition to the term that is described as aggressive care. And so this term can also inappropriately label the preferences of African American patients with the association of high healthcare expenditures. However, in the literature, it does show that most African American patients actually do prefer a comfort-oriented care at end of life. However, for those minority patients who do wish to seek measures of prolonged life, long life care, they're often perceived as being fairly difficult for advocating for their continued care. Or sometimes clinicians may have a perception that discussing these end of life conversations with these patients and or their family members, it can be difficult as well. So ultimately, all of this can inadvertently, result in a higher proportion of African Americans not being able to receive non-goal concordant care as compared to their counterparts. Now, the literature even show that even if an African American has their goals outlined and written out, they're less likely to have them followed by the clinician as compared to their counterparts. And also, sometimes the clinicians are less likely to document these end of life conversations with the African American patients and their families. And so the authors of this article, they noted that this failure to achieve goal concordant care, it is kind of recommended to be viewed through the lens of what they described as a medical error that can harm not just the patient, but also the families. And inadvertently, this can also be a clear indication of racism, which is not just defined by racial prejudice or racial injustice, but also that systemic oppression is evident. So, we want to be able to provide clinicians and healthcare affiliates with some insight on the importance of spirituality and religion. So in the article, they were able to utilize the Pew Research study, and from this, they were able to collect data on about 10,000 random US adults who were able to self-identify their religious affiliation. And so of the Black adults who self-identified as Christian, there were accounted for about 3/4 or 75%. And of those, 85% of those individuals believed in miracles. Now, the idea of miracles stems from the ancestral traditions of the earliest African slaves. And so history has also shown that the survival of the treacherous Middle Passage, which was the transportation of Africans to the Americas via ship, was considered very miraculous. Now, these individuals, they faced gruesome, horrendous, and even hostile conditions on their voyage. And when they could not be able to practice their traditional religions, they were able to resonate with the God of Christianity as a God of miracles based on the biblical narratives of him delivering the Hebrew slaves and the other miraculous works that he was able to perform. So the African American Christians, they framed their survival and their thinking over the past 400 years as miraculous. And so now we want to be able to tie in their religious spirituality with the medical community. And so, due to history, we are all relevant of knowing that medical mistrust, there is some reservation regarding seeking medical attention, just based on the different experiences of the past, including the Tuskegee experiments, as well as Henrietta Laxdale's, known as the HeLa cells. All of these areas represent historical events that kind of set the foundational preference for the community having reservation for seeking medical care. And so, because of this, African American Christians have learned to depend on the God of God's miraculous healing power and also the scriptures and biblical healing scriptures and testimonies. So, in the African American community, religion has served as not just an emotional stabilizing factor, but it is helping to contribute to the mental as well as the physical well being of the people in the African American Christian community. And some of the scriptures that you may hear if you're in a healthcare setting caring for those of seriously ill African American Christians include some scriptures coming from Psalm chapter 41, verse 3, which I quote. It says, "The Lord sustains them on their sick bed and restores them from their bed of illness." Another verse you could also hear comes from Psalms chapter 103, verse 3, which says, "Praise the Lord, O my soul, and forget not all his benefits, who forgives all your sins and heals all your diseases." So, other areas that African American Christians hone to are also the testimonials and the praise reports, which are shared stories about the experiences of God's faithfulness. And these experiences, they've helped to mold and be methods for encouraging other believers and helping them through their illness as God has helped them or someone that they love. And also, now to kind of put everything into perspective, this combination of having a strong trust in God, a belief in miracles, and distrust in the clinician, these can influence and also inform the decision making of a seriously ill African American Christian patient to request what they would consider continued high level of care or medical intervention, even when recommendations call for supportive care. And so, what can we do as healthcare providers and healthcare affiliates? Well, these are some of the recommendations that the authors propose to be able to allow us to be able to, in efforts to provide goal concordant care to this community of individuals. Now, their first recommendation is we should possibly go ahead and avoid the use of aggressive care and lean more towards a language that is more respectful and demonstrates respect and understanding of the culture as well as the beliefs of the African American Christian community, while also still balancing our role for professionalism with medical ethics to do no harm. One of their methods for achieving this balance is utilizing or engaging in critical reflection of bias and role performance, which can be done through implicit bias training. Now, through this method, one would be able to perform a critical reflection of oneself and their bias, and may be able to perform this during role performance. Now, they also suggest utilizing a term that they call prognostic humility. And this term is described as sharing prognostic information in a culturally sensitive manner by respecting the patient and the family's right to maintain hope, and also giving room for their belief in miracles, but also understanding that their beliefs in miracles are not synonymous with meaning that they desire what we would consider prolonged life measures. So, we as providers, we want to be able with all of our patients, but particularly those from the African American community, we want to be able to exhibit patience and respecting the hesitancy of decision making, especially giving the long history of mistrust within this medical community with the community or population of African Americans. It's always good that we do not counter their hesitancy or counter medical mistrust with defensiveness or disagreement, but rather have an open mindset for respectful communication. And another recommendation is incorporating African American stakeholders who live in the community and work in the community, to be ambassadors to the healthcare system in order to potentially increase community trust in the healthcare system as well as their providers. So overall, as healthcare providers and affiliates, we should all want to always approach our patients with sensitivity and also humility, but also a sense of curiosity during vulnerable times in efforts to be able to help patients deal with very critical conversations, including those regarding end of life. So, the key message that I would like to you all to take away from my portion of the discussion is the perspective that end of life, suffering, and dying, they're strongly influenced by a person's life experiences, their cultural identity, and for some, it would be their spiritual affiliation. However, most African Americans, they do endorse desiring a comfort-oriented plan of care at end of life, and you want to be able to allow them a safe space and also support the African American Christian patient to be able to absorb and process clinical information through their preferred spiritual lens. All of this is very critical in efforts for us as healthcare affiliates and providers to be able to provide goal concordant care.
Right. And so I kind of want to go a little bit deeper when she was talking about the spirituality and African Americans and healthcare. In our area in the South, we know many of our patients have very, very strong religious beliefs and values. Sometimes those beliefs cause conflict, especially when the medical prognosis may be poor. And we have seen patients actually suffer because there is this mistrust in the healthcare system, while there's also these strong religious beliefs. And so we can unknowingly cause some not only physical problems due to this lack of communication between the provider and the family and patient, but we can also cause them some spiritual distress as well. And when that occurs, then they're less likely to hear anything we have to say medically, and they're not able to make those wise, informed decisions that they're asked to make. And so the first step in understanding how spirituality plays a role in healthcare is to understand there is a difference in religion and spirituality. So religion is the beliefs and practices associated with an organized group, such as a synagogue, congregations, different denominations, or faith communities, whereas spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or sacred. So one thing that I've found to be helpful in my role as palliative care nurse practitioner is trying to figure out, does this patient or family have any type of religious or spiritual connection, because this is a huge part of the assessment that's often missed by providers. And I normally will ask, what matters to you the most? What helps you get through this horrible disease that you're going through? What helps you get through trials? Many times they will open up to you, because most people who have a strong faith are eager to talk to you about it. Sometimes they won't. And so you may need to look for visible signs if there is faith, or if there is a spirituality or religion at play. There may be tattoos, there may be Bibles, you may see crosses, you may hear them say different comments in your conversation. One thing that we hear a lot is, I have faith. The doctors don't know the God that I serve. The God that I serve is able to do it all, and he's a fighter. God has got him. And I think some providers almost feel a little bit rejected in that moment, because they're giving it their all. They have all this training. They're doing all they can to save this person. Like, this is not a spiritual matter. This is health. This is science. But in that moment, they don't care about what you went to school for. All they know is someone they love is hurting and or dying, and you're only giving them scientific methods or proofs or research, but all they need you to do is sit down and meet them where they are. So if you have a patient or family that is holding on to their faith and it's clouding their ability to receive medical information, talk about that faith. Let's get to the root of it. To them, when they start saying they're waiting on a miracle, what does a miracle look like for you? And in our mind, we see a miracle as, she thinks her mother's going to come off the ventilator and they're going to go home and live happily ever after. She may not even be thinking of that as a miracle. I've seen cases where a miracle to her is, my mama could just open her eyes and see me, or my daddy would just be able to eat a hamburger. Like, so we have to remember that it's not our thoughts and values that are at play, it's theirs. But we don't know how they're truly feeling if we don't take that time to sit and assess. So when they talk about miracles, I encourage you all, don't shrink back. That's when you go forward into it and walk into it with them. Because I know if they have a strong faith in God, then they're more likely to receive an understanding that, okay, you're waiting on a miracle, you're waiting on something supernatural to happen. We're waiting on that with you. Even as a provider, if that's not your faith, you don't believe in miracles, that has nothing to do with healthcare, you don't have to take away their hope if that's something that they are hoping for. Because at the end of the day, we go home and we rest peacefully, but they are still trapped in a nightmare. And so if all they have to hold on to is that hope and that miracle, then that's what we'll say to her. I'm hoping and praying for your miracle too. You don't have to take anything away from that person, but in that moment, you're acknowledging how they feel, while also admitting and being honest about whatever that prognosis is. We're not taking away from the fact that your mama is dying. We're telling you we hear you and we're on the same page as you. If you can align yourself with the patient and their family, then they can receive the information a lot better when you do give them bad news. Many times, they'll use their faith sometimes to avoid hearing that difficult news. And so you'll have to be able to decipher, are they holding on to faith because they truly are believing that something supernatural will happen, or are they holding on to the faith as a way to shut all of us out? And so sometimes it's also beneficial to enlist the help of a chaplain if you don't feel confident in your ability to have a spirit or to perform a spiritual assessment on someone. When they mention that they're waiting on God, or when they say it's God's time, that's normally when may start a code status discussion, because we can't say we're waiting on God for a miracle, but then we still also need them on this machine and man and medicine managing things. So I've been able to reason with people before when they say they're waiting on God. When God says it's time, then that's when mom and daddy will go. Well, we won't ever give God a chance to say it's time, because we will keep intervening as long as he or she is a full code. And so finding ways to communicate that without being seen as their enemy or being against their faith is going to be very important in order to produce the best care or deliver the best care for that patient. And also remembering, if a natural death is desired, we want to make sure they know what that looks like. Oftentimes we kind of skip over things. You want us to do everything for your mom? Yes, do everything. They normally don't know what everything means. And so in their eyes, they're trying to show honor to their parent or to their child or family member by telling us to do all of those things while they're waiting on God to also work too. And so you have to get to the bottom of where those comments are coming from and show them respect, even if you don't agree with what their thoughts are on things. And I always tell people, and it may be helpful to some of you, they feel as though they're giving up on someone they love, or they feel as though their faith is weak if they are not able to continue lifelonging measures when the doctors are saying it's non-beneficial at this point. So I remind them, you can't give up on a body that's already started giving up. So you're not giving up on your mother, her body is giving up on her. And what we do is try to help support them when they're in that time of need. And if they need their faith to help keep them going, we let them have that. I don't have to take that from you. And we also want to encourage them to think about what would the patient say. So when I'm having a goals of care meeting with family, I always ask, what would she say if she could see herself right now? Is this something she would want? Because a lot of times families will struggle with making decisions because they feel like it's wrong. And I like to reassure them, any decision that you make out of love, it's always the right one. I don't care who says what. I don't care what the science shows. I don't care. I mean, I care what the doctors say. But, when I talk to them, I make sure they know your loved one will love you for making those decisions because you love them. So it can't be a wrong decision that's being made regardless. Because as they say, God will have his way either way, whether we stop things, whether we continue things. And so as healthcare providers, it's not my right to tell anyone what they should or should not do. That is not my family. That's not my loved one. It is my role to help support them and make sure they understand what the doctors are expecting. So we never say she's never going to get better. We don't know that. And especially in somebody that has a strong spiritual faith, you don't write it off because see, they're waiting on a miracle. So what we say is, well, the doctors are not expecting her to improve. So let's talk about what this looks like. If she were to improve, this is likely what things may be. If she doesn't improve, this may be what we need to do. And so we do a lot of palliative extubations here. And at the end of those extubations, yes, someone likely has lost their life, but their family has peace because they were allowed the time. People start grieving before death happens. And so as providers, we have to be in tune and recognize a lot of their anger, a lot of their frustration, a lot of what we see as aggressive is actually people who are hurting and grieving. And so I always just remember, as we go through our healthcare career, we have to be willing to listen to them. Whether we agree with their beliefs or not, we have to meet people where they are. Any questions for us?
I just want to say an amazing, amazing, amazing talk.
Oh,
Truly.
thank you.
Thank you so much for what you do.
Thank you. I'm glad you appreciated it. It's not easy. Thank
We
you.
we would love to have you speak to our fellows at Tulane. If you'd be interested.
Yeah, we'd be interested. Just send us an email. I have to convince Dr. Perkins. Just send us an email because I do believe the more you're educated,
Yes.
many providers don't even realize that they may be causing more harm. They don't even know because I don't think people are intentionally trying to hurt other people. We have an obligation to do no harm, but if you don't know something, what is that called? Unintentional bias.
Mm-hmm.
It would be wonderful. If you don't mind putting your email in the chat,
Yes,
I'll
sure,
email
we
you.
will.
Thank you.
And I want to apologize to everyone. I don't know why today it required a password, but the password is always LMHPCO. We are recording this session so that folks can have the option of looking at it in its entirety if you missed any of the presentation before.
I just want to speak up real quick. I'm Mary Raven. We're all in Baton Rouge, and I would imagine we take care of very similar population to what y'all are doing up there in Tupelo. And all of what you're saying, I thought was, we were taking notes. I thought there's some great things, scripting, some great new ideas. A lot of them familiar, but some new ways to describe things, and we appreciate that so much. And the one thing I would just reiterate is, as a white person who often sitting in rooms with a very large African American family, what has always helped me, which you touched on, is humility, right? Taking the time to really listen and making eye contact, understanding the family structure that you're in. And how they're making decisions, unconditional respect, and I like the humble prognostication. Always beginning with, "I'm not God. I can't tell you your time and day, but what I can do is give you an idea, if that's helpful." So all of those things help establish trust. And some of the most rewarding meetings I've ever had have been with African American families, because by and large, they have a much stronger spirituality most of the time. And they use that spirituality to their advantage. And sometimes they use it as a shield to the reality, but often it's very much used to their advantage to help them find a way through. So if you can do this well, it makes your job so enjoyable.
And I will tell you, as a Black provider, thank you for that, because it is very helpful when providers that don't look like me can acknowledge that there is some differences. We're not all, it's not about equality, it's about equity. Sometimes we got to meet people exactly where they are. And when you are able to find that common ground, no matter the color of your skin, and get them to open up to you and to trust you, you are that bridge between them and everybody else in the hospital. And so our goal is to make everybody be comfortable, because it's a difference, cultural differences. I may be in a room with some families and they're silently crying. I may be in a room with others and they're jumping and shouting and praising, and people are thinking we need to call security. But no, we don't need to call security. This is normal. But if you don't take the time to get to experience other cultures, then it feels very abnormal to you. So thank you for taking that time.
Yeah. Well, this is a great talk. We have a fellowship program too, so we'd love for you to come talk to us.
Okay, awesome. Well, I've attached my email. Dr. Perkins, you may not can catch her as easily as me, but we would love to try to make something happen. We would be honored to.
That'd be awesome.
Mary, maybe we could do a joint fellowship faculty for all.
That's what I'm thinking, Alex. I think that'd be a great idea.
I'll include you in this
Just
email.
send us the information. We'll be glad to.
Fantastic.
Jamie, thank you for this opportunity.
Oh, well, thank you for but I have a question, and in light of current political winds, let's put it, there's been a big pushback on terms like equity and diversity and things of that nature. I know in terms of patient care, as long as you stick with where the patient is and you can connect with that patient, all of those issues sort of wash away. But in terms of our institutions, I'm just wondering if, and this is not just for your hospital, but for other hospitals, are you all, or in your practices, are you seeing any pushback on efforts to expand our understanding of diversity, equity, belonging?
Well, I know here at our hospital, this is a new year and new times in the political system,
Right.
but I know in recent years, I'm also part of our diversity. I work with our diversity, equity, and inclusion officer here to try to give more education out to minorities. We're not wanting anybody to be treated any better. We just want all people to be treated the way they should. And so we're trying to get out education. We had a translator that came and helped us deliver a commercial for the Hispanic population about their blood pressure. We've also had meetings with the local barbers and church leaders here to try to also educate. If nobody comes to the hospital, they're going to go to the barber shop and the beauty shop to get their hair done. And so we are able to reach. And the reason why there is such a big push to reach minorities is because that's where you see the majority of our mortality rates when it comes to the heart disease and the high blood pressure. And the minorities are the leaders in all of these illnesses. And a lot of it, as we already talked about, there's a lack of trust in the healthcare system. So you avoid going, you don't have to deal with these issues from the medical team. And so in not going, their bodies are constantly damaged. And
Right.
that puts more stress on the healthcare system. So it's actually quite beneficial for everyone to try to educate so that we can help our whole system, which is for everyone.
Said.
Hey, Jamie.
Anybody? Yes, sir.
I'm sorry, this is Rob Tasman with the Francis
Yes.
Missionaries, our Lady
Yes.
Health System. Just want to give you an update as to where we are with our system. So sometimes this is an issue of semantics as compared to the practicalities, right? And
Exactly. That's the silliest part of it, is that it's about semantics most of the time.
Yes, exactly. So our health system has decided we are certainly not pulling back on any of the services that we provided in what was for us the traditional DE&I space.
Mhm.
We are, however, sort of rebranding the department. We're calling it Health Equity and Belonging. And that's hopefully a more inviting way in this climate to have all of our team members accept the realities that exist. And it's another way as well, the health equity piece, to focus on those social determinants of health and really drill down on those, which, as we all know, brings in the cross section of all the different ethnicities and issues that we're facing amongst populations. So
Right. And Rob, we're doing the same thing with this organization in terms of we had a DEIB task force where it's no longer branded as the DEIB. We're now going to organizational excellence. And it's about the semantics. And I don't want our politics to interfere with good patient care.
Correct.
And we've gotten to this point of understanding, of being much more aware of our responsibilities in providing good patient care, meeting patients where they are. I don't want to lose any of that in the political minefield that's out there. So thank you. And I don't mean to put you, Dr. Lee, I don't mean to put you on the spot or Robin on the spot, but you all are probably the most affected in terms of executive orders being in the VA system. Have you seen any pushback on your efforts to make sure that people are getting good care? Not in terms of furthering good care through diversity, equity. You want to
Yes.
say? You want to say? I mean, it is being recorded, so you may not want to say anything at this
Well, I
point.
think I can safely say that we've been asked to remove that language
The
from
language.
everything that we teach or any papers that we hand out.
Semantics.
Yes.
Again, semantics. Okay. I just want to make sure that we're all of us in the healthcare field are operating on the same wavelength with regards to the importance of this new understanding that we have around patient care. Okay.
And
Any other thoughts, comments, or discussion?
I just also wanted to chime in and also to commemorate or at least applaud these organizations who are recognizing, that it's all about semantics and haven't decided to dismantle these very important initiatives and finding ways to work around the wording in efforts to continue to provide high quality goal-concordant care. And also, I would also like to highlight the authors of this actual research article. I mean, the work is not my own, and I just really have to commend them for putting together such a beautiful work of art so that we could be able to have these very meaningful discussions around this very important topic, especially given the climate of our society today. So for any of those who are connected, I know they're affiliates or part of you all's program and organization. We thank you all so much, and I'm pretty sure they're continuing to do very, very great work.
Yeah, we just got a question in the chat box, and I was thinking the same thing. Is there a way for us to link to that article
Yes,
without having to go through a paywall or something like that? Is it? Yeah,
yes. What I can do is, we're using a computer. I can send it to the email address. Well, that's if you want to send it, but I can send the actual link.
Okay.
What I can do is, if they can share, if I send the link to you, Mr. Jamie, would you be able to disperse it?
Sure.
Okay.
Yeah, and if you actually have a PDF copy
Yes,
of
I
that,
do.
if you have the PDF, what I can do is I can distribute the PDF to everyone on today's call.
Gotcha. Yes, I'll email it to Kalisa and we can upload it
Okay.
for
Yeah.
you all.
We can actually, that would probably be the best way if and people would actually have a copy of the article. Yeah.
Gotcha.
Wonderful article.
Yeah. Thanks for the question. Any other questions or comments before we close out today's session? Was there any other business of the super group, the palliative care super group? We will be meeting again. We meet on a quarterly basis, and Dr. Cantro, are you still on? And do you have some ideas in terms of some of the topics we will be covering the rest of the year? Dr. Cantro is still with us. But I want to thank everybody who has been on today's call. I don't know, the palliative care task force has not announced what the remaining topics, remaining 3 topics will be for 2025, but we do have three more quarters to come up, and as soon as those get out, we'll be sending them out to everyone. Any final words before we close out today's session? Well, again, I want to thank Dr. Perkins and Ms. Mickell for being with us today and giving us some very rich food to consider today. Thank you for your time and attention.
Thank you.
Thank you very much.